Medical University, Jaipur, Rajasthan, India. My presentation is long-term clinicoradiological outcome of cervical fusion with polyether ether ketone versus cervical disc arthroplasty. This is a double-blind randomized control trial that was published in Asian Journal of Neurosurgery in 2021. Here we can appreciate that this is the X-ray lateral view after implanting the artificial cervical disc, and here we can appreciate X-ray lateral view after implanting the peak spacer device. The introduction: anti-cervical discectomy and fusion and cervical disc arthroplasty are both equally effective treatment for patients of cervical degenerative disc disease. These both are the well-known treatment. While several studies have compared the immediate and short-term clinical and radiological outcomes of both these procedures, however, the best of our knowledge, there have been a few studies comparing long-term clinical and radiological outcome. Here in my study, I have tried to compare both these procedures as a long term. So this is a double-blinded randomized control trial where I have tried to long-term clinical radiological effect of ACDF versus CDA. Aim of my study was to compare the pain score, cervical kinematics, and radiological outcome. Setting and design of my study was, the study duration was 2010 to 2019, and it was conducted in a department of neurosurgery in a tertiary care hospital attached to a medical college in India. The material and methods were: the type of the study, as I have already told, this is double-blinded randomized control trial and sample size of total 60 cases, 13 each group. Inclusion criteria were: age of the patients were 18 year to 65 year, cervical disc degenerative disease requiring surgical treatment at 1 level or 2 level from C3 to T1 for symptoms of cervical radiculopathy and or myelopathy with or without axial neck pain. And another one, the patients who failed conservative treatment lasting at least 6 weeks for disc herniation with a radiculopathy or disc herniation with myelopathy or compressive lesions that was confirmed by the MRI. Exclusion criteria were: post laminectomy with kyphotic deformity, translational instability, ankylosing spondylitis, rheumatoid arthritis, ossification of the PLL means posterior longitudinal ligament or diffuse hyperostosis, and patients with insulin dependent diabetes mellitus, pregnancy, metabolic bone disease, and non-discogenic pain sources. These were the exclusion criteria of my study. The randomization was done as a total of 60 patients were included in my study, randomized in 2 groups in 1-to-1 fashion. Allocation concealment was ensured by using sealed envelope for allocating treatment group to selected study participants. Though patients could not be masked about type of surgery, outcome was measured by independent trained observers, and data analysis were blinded to the type of surgery undergone by the patients. 5 patients were lost to follow up in each group, and finally 25 patients in each group were included in the final analysis. The patients were followed up at fixed interval post surgery and continued to be in the follow up, and final evaluation was done 5 year post surgery. In this study, we evaluate the clinical and radiological finding pre-operatively and the final follow up 5 year post surgery. Clinical and radiological evaluation are done. The clinical criteria which were included are visual analogous pain scale that are for the pain intensity from 1 to 10, neck disability index for neck specific disability, and cervical range of motion measured by goniometer. All were measured pre-operatively and every follow-up thereafter. And radiological evaluation done by the MRI and X-rays. MRI to confirm the diagnosis and extent or the level of involvement, and X-ray, pre-op and post-surgery lateral cervical spine radiograph with flexion and extension view at each follow-up, and final at 5 years. Surgical procedure. All procedures were performed by a single operative surgeon. Incision was transverse skin incision made on the right side of the neck, as the surgeon was right-handed. Anesthesia used the general anesthesia. Here ACDF with PEEK implant filled with autologous bone without anterior cervical plating or implantation, or the Prestige Medtronic artificial disc prosthesis was performed. Patients in the PEEK group were given to a soft or hard collar for 6 weeks post-surgery for the pain purpose. Statistical analysis were used the Wilcoxon signed rank test, Mann-Whitney U test, Fisher's exact test, and R software version 3.6.0 was used to statistical analysis. The results at final follow-up, CDA group found the significant improvement in cervical range of motion, sagittal range of motion, and functional spinal unit, while disc height was more or less maintained. While in the PEEK group, there was a significant decrease in the range of motion and functional spinal unit, and significant decrease in the disc height. Here, this is the demonstration of the baseline character which are included in my study. The age in the CDA group is mean age the 34, while the PEEK is 41. And in a purpose of the sex ratio, the female 6 in the CDA and PEEK is the 4, male 19 in CDA group and PEEK in PEEK group is 21. And myelopathy was 8 in the CDA group cases, and in PEEK groups there were the 7 myelopathy. There is a no demographic changes found in the both group, and that was not significant. Here this table is showing the comparison of clinical finding in the VAS score, visual analogous score, and the NDI score, neck disability score. We can appreciate here the median value on the CDA preoperative 8.3. In follow-up it was 3.6, while in the PEEK it was 8 and 3.9. More or less both are seems to be VAS score was improving, and also there is p value is also not significantly changed. It means in both the CDA group or PEEK group, both the VAS score was improved post-operatively. Same here we can appreciate the NDI score. There's from CD and CDA group, it from 26 to it becomes 7, while in the PEEK it becomes 26 to 7. In both the groups it improved, and also, and we can appreciate here it is also not significantly different in the both groups. In this table, we can appreciate there the cervical range of motion in the overall cervical range of motion, lateral flexion range of motion, or rotational range of motion. We can appreciate here in CDA group it from 88 to it become 97, while in PEEK group it from 83 to it decreased to 68 group, and the difference was also significant. Means the cervical range of motion is improved in the CDA group while it is decreased in the PEEK group. Same we can appreciate here in the lateral flexion it becomes 71 to 79, and rotational it becomes 112 to 142, while in the PEEK groups it becomes 71 to 57, it decrease, and it's same here in the rotational ROM it from 112 to it become 91. Means CDA group, the cervical range of motion, overall, lateral flexion, or rotational ROM, it improved, while in the PEEK group is decreased. And we can also appreciate our results. These differences were significant. Here, this is a radiograph which is better appreciated here, that the CDA group, it rotational ROM is improving while it is decreasing in the PEEK group. Same here in cervical range of motion is improving, while in PEEK group it is decreasing. And here in lateral flexion of the neck is also improving in the CDA group, while in PEEK groups it is decreasing. Here again, as we have appreciated earlier results, also we can see here in CDA group the sagittal ROM upper level, sagittal ROM lower level, and sagittal ROM implanted level. In all these three groups, at 3 measures, the CDA group it become 9.1 to 9.9, here 8.8 to 9.3, 12.6 to it become 13. It means it's all are improving. While in P group, it become 9.8 to 9.5, 13.2 to 10, and 13 point again decrease. Means it is not improving. It is while it is decreasing, and these differences also significant here. Again, we can appreciate here that there is a decreasing mode of the P group, while it is improving in the CDA group. Again, in this table, we can also appreciate that functional spinal unit. We can appreciate here CDA group, it become 8.2 to 6 point, slight decrease is there, while functional spine range of 14.10 to 11.2, slight decrease is also here, while in P group it was 7.9 to 2.10, there's significant decrease in the functional spinal unit flexion. And same here, we can appreciate the functional range of motion is become 14.10 to 3.80. These differences also significant. Here we can appreciate overall cervical alignment flexion and overall cervical alignment ROM. You can appreciate here in the CDA group is 25 or 25.4 to 26.20, and overall cervical at 50 to 52. It's improving. While in P group, it overall cervical alignment flexion is initially 22.8, it become 14.7. It means decreased, and overall cervical alignment ROM from 50.50 to 34.10. It's been decrease, and this difference is also significant. Here again, we have illustrated in this table the disc height implanted level, posterior intervertebral height, disc height lower level, posterior intervertebral height, disc height upper level, anterior intervertebral height, disc height lower level, anterior intervertebral height. We can appreciate here in the CDA group, these are the improving, while in the P case group it is all decreasing, and these are also, we can see the value of P, it is all are significant. In our discussion, our study compare the long-term clinical and radiological outcome of CDA versus P in patients with cervical disc degenerative disease. While the visual analogous scale neck disability score improved in both subset of patients, however, no difference could be observed between the two groups for both these scores. Similar findings were reported by China by Ziling Zhou et al. And Shai Zayas et al. However, in another similar study by Zhang et al., better improved in the neck disability score was reported in the CDA group as compared to the ACDF group. When in our study, we compared the CROM, cervical range of motion, in the two groups of patients. We found significantly better range of motion in patients undergoing cervical disc arthroplasty as compared to those in the P group. Similar results were reported by Ziling Zhou et al. With preservation of the range of motion of the C2 to C7 in the CDA group, whereas in the ACDF group decreased the range of motion was noted post-operatively. Several RCTs comparing the range of motion in these two groups have also reported similar findings. In our study, the sagittal ROM was compared between the two groups. The P group shows a reduction in the sagittal ROM, while an increase in the sagittal ROM in all plane was noticed in the CDA group. The similar results have been reported by the Paris GM et al. From Spain and Radcliffe K et al. From the China, and also by the Jensen ME et al. In the published meta-analysis of RCT comparing ACDF versus CDA for two contiguous level of the cervical disc degenerative disc disease. In our group, the functional spinal unit showed a steeper decline in the P group as compared to the CDA group. Similar findings have been reported in the RCTs from the China and the Korea. When we compared the disc height between the two groups, was observed that the disc height was more or less maintained in the CDA group, while those in the P group demonstrated a significant decrease in the disc height. Several other authors have also reported similar findings undergoing the better long-term radiological outcome in patients who undergo CDA for the cervical disc degenerative disease. our study have some advantage of being one of the few long-term follow-up studies in the patients undergoing CD and ACDF in India. As per my knowledge, there are not much studies have done in the India on this two groups. Further, being a closely monitored group of patients, there were no dropout among the subjects, which could have affected the results of our study. Limitations of my study were a small sample size in each group, a single observer for interpreting the results of the two groups, the confounding factor of heterogeneity of single and bilevel case of cervical disc degenerative disease in both the groups. Conclusion of my study was cervical disc arthroplasty offers better result in terms of cervical kinematics and radiological outcome as compared to ACDF in patients of cervical disc degenerative disease. This is CDA is more physiological approach and it prevent adjacent level disease as a long term. These are the references. Thank you very much for your attention. Any questions, sir?
Thank you, Dr. Vijay, for a nice presentation, and I hope participants have benefited by your research work. And as you rightly mentioned, disc arthroplasty